Shyam, concerning glaucoma surgeon, on talk on aggressive push to crisis, secondary push mechanism glaucoma.
Good morning, everyone. I am Dr. Priyanka, and I am going to talk on aggressive push angle closure in crisis. So, the angle closure caused by posterior pushing mechanism is mainly caused by the peripheral iris being anteriorly displaced by aqueous ciliary body lens vitreous or forces posterior to the vitreous. The rich 4-point classification of angle closure is based on the originating pathology at various anatomical levels. First, at the level of iris, maybe due to relative pupillary block or iris thickness and architecture. Second, at the level of the ciliary body, can be due to plato-iris, configuration, syndrome, and pseudo-plato-iris. Then iridociliarisis and sordid lesions of the ciliary body. Third is at the level of the lens, can be due to enlargement or intumescence, dislocation or subluxation of the lens. Posterior to the lens, the factors are malignant glaucoma, choroidal effusion, angle closure after scleral buckling procedures, after panretinal photocoagulation, after retinal vein occlusion, and posterior segment tumors. Now coming to the pathophysiology according to various anatomical levels. First, at the level of cornea, can be due to smaller corneal diameter, smaller radius of anterior and posterior corneal curvature. Coming to the anterior chamber, it can be due to smaller anterior chamber width, area and volume. Coming to the iris level, can be due to thickness, rigidity, dynamic increase or lesser reduction in iris volume during dilatation. At the level of the lens, it can be due to thicker lens, smaller radius of anterior lens curvature and more anterior lens position. Then shorter axial length and choroidal expansion are also other factors. Coming to the diagnostic options, the first one is dynamic darkroom indentation gonioscopy and then followed by imaging of the anterior chamber, which includes UBM and ASOCT. So gonioscopy is performed with a 4-mirror contact gonial lens and corneal indentation is subsequently performed to distinguish iridocorneal apposition from synecdoche. Finally, the slit lamp illumination is maximally increased to constrict the pupil. Thus, this technique allows a dynamic study of the peripheral iris in relation to the angle structures while in motion. Then coming to UBM, it utilizes high frequency ultrasound waves and provides a cross-sectional image of the structures in the angle and the posterior chamber that are not visible by slit lamp biomicroscopy or gonioscopy. Then coming to ASOCT, it utilizes low coherence light waves and provides high resolution cross-sectional images of the anterior chamber. Since it's a non-contact operation, it is more patient-friendly than UBM. And however, ASOCT cannot image structures posterior to the pigment epithelium of the iris where light transmission is limited. Provides quantitative measurements of the angle, anterior chamber depth and central corneal thickness. Gonioscopy provides a wide panoramic view extending across the entire quadrant, whereas UBM and ASOCT provides thin cross-sectional images limited to only one meridian at a time, and hence localized pathology can be missed. So currently, imaging is used only as an adjunctive tool for gonioscopy. Now, angle closure originating at the level of ciliary body can be due to plato-iris configuration, that is an iris with a flat central surface and angulated sharp drop-off of the peripheral portion. Plato-iris syndrome develops in eyes with plato-iris configuration despite the presence of a patent laser iridotomy. This is the UBM of a plato-iris syndrome showing normal central anterior chamber depth and iridotrabecular contact caused by anteriorly positioned ciliary body in the presence of a patent PI. Here you can see the first picture shows the indentation gonioscopy in an eye with plato-iris syndrome, creating double hump iris contour. Second picture shows the UBM of the same eye showing appositional closure of the angle, plato-iris configuration and anteriorly positioned ciliary body. Whereas the third picture shows pressing on the cornea with the ultrasonic probe, resulting in opening of the angle and creating the double hump sign. Plato-iris syndrome can be complete or incomplete depending on the extent of the iris occluding the trabecular measure. If it is complete, it can result in elevated IOP and it results in an acute attack spontaneously or following pharmacological pupillary dilatation. Whereas in the incomplete form, there won't be any IOP elevation. Now, secondary or the pseudo-plato iris is caused by cyst of the iris or ciliary body. Lens-induced glaucoma can be due to lens subluxation or dislocation, exfoliation syndrome, and in younger patients it can be due to ciliary block, Weil-Marchesani syndrome and Marfan syndrome. Mature senile or traumatic cataract with intumescent or swollen lens causes acute attack of phacomorphic glaucoma. Idiosyncratic reaction to several medications can also cause lens-induced glaucoma. Gonioscopy showed a volcano appearance of the iris surface draping over the anteriorly displaced lens, which is called as the Fuji sign, and visible ciliary processes can also be seen. UBM revealed a markedly shallow anterior chamber and iris draping over the enlarged lens and angle closure in the presence of a patent PI. Ocular biometry parameters quantify the extent of the lens mass that crowds the anterior chamber angle, and these are lens axial length factor, relative lens position, and the lens vault. Now coming to malignant glaucoma, it is first described by von Greffe, and the other terms are aqueous misdirection, ciliary block glaucoma, and lens block angle closure. Incidence is 0.4 to 6% of case of incisional surgery for PACG, more commonly seen in females. The epidemiology can be seen in both phakic as well as pseudophakic eyes, and it may be seen after various ocular surgical procedures. These are the rare ocular associations of malignant glaucoma. The risk factors are axial hyperopia, chronic angle closure with Plato-iris configuration, nanophthalmos, and history of malignant glaucoma in the fellow eye. Coming to the pathophysiology of malignant glaucoma, it is mainly due to the aqueous being misdirected into the vitreous and resulting in an increased posterior segment pressure, which causes anterior movement of the lens iris diaphragm, thereby resulting in a secondary angle closure. So the key features are shallow anterior chamber, both central as well as peripheral. There is no iris bombay, and also patient has high IOP. Normal posterior segment anatomy, and the first symptom may be improvement in near vision, which is secondary to myopic shift due to the lens iris diaphragm being pushed forwards. The patient also presents with pain and inflammation and corneal edema. The points to notice: if there is no iridotomy or if patency is in doubt, an iridotomy must be created to rule out pupillary block. If there is a patent iridotomy and a high IOP, then UBM should be done to rule out choroidal detachment and suprachoroidal hemorrhage. If filtration surgery is present, a serial test should be performed to exclude a wound leak, particularly if IOP is not significantly elevated. So, investigations: B scan is done to rule out choroidal detachments and suprachoroidal hemorrhages. UBM as well as ASOCT also helps in the diagnosis of malignant glaucoma. Now, angle closure due to choroidal effusion. Idiosyncratic drug reactions can cause bilaterally shallow anterior chamber and angle closure. The mechanism is by uveal effusion with or without ciliary body swelling. These are the drugs which cause bilateral shallow anterior chamber. Now coming to the systemic inflammatory diseases, it can be due to SLE or VKH. They cause bilateral 4-quadrant annular choroidal effusions and angle closure, which are unresponsive to medical therapy and laser iridotomy. Retinal conditions like CRVO, PRP, scleral buckling procedures can disrupt the retinal and choroidal vascular permeability and interfere with the venous drainage of the uveal tract. Thereby, it causes a unilateral shallow anterior chamber, both centrally and peripherally. Gonioscopy can be done to diagnose the condition. Intraocular tumors like malignant glaucoma, retinoblastoma, and metastatic tumors can displace the iris lens diaphragm forward, leading to angle closure, or by direct infiltration into the trabecular mesh of synovial formation, hyphema, and by iridocyclosis. The diagnosis is done by ultrasound imaging, paracentesis, or vitreous tapping for cytological examination. Coming to the treatment part, the goal of treatment is mainly to reduce the IOP, to reopen the anterior chamber angle and prevent recurrent angle closure, and also for controlling residual IOP if irreversible trabecular mesh dysfunction has occurred. So the medical treatment is mainly by aqueous suppressants, miotics. They are useful in angle closure with an element of pupillary block. Prostaglandins are given in patients with angle closure whose angle is still partially open. Coming to the laser treatment, can be iridotomy or iridoplasty. Iridotomy is done if there is a component of relative pupillary block. Iridoplasty is done if there is residual appositional closure in the presence of a patent PI. They are also useful in Plato-iris configuration and lens-induced angle closure. Goniosynoculisis. It's a surgical procedure designed to strip the pus from the angle wall and restore the trabecular meshwork function. The synechiae are mechanically separated from the trabecular meshwork under direct visualization through a gonial lens. It is highly successful in eyes with recent synechiae. Coming to the treatment of lens-induced glaucoma, drug-induced swollen lens usually responds to medical treatment, and they spontaneously resolve after cessation of the precipitating medications. Intumescent cataract, subluxation, or dislocation of the lens are usually unresponsive to medical therapy, and laser iridotomy should be performed in all these eyes to eliminate the element of pupillary block. So removal of intumescent lens is the definitive treatment of achomorphic glaucoma. Removal of a clear lens is useful in eyes with recurrent attacks or unresponsive to medical and laser treatment. However, synachial closure, if persisting after lens removal, should be removed by goniosynachial. Now, malignant glaucoma treatment is mainly by medical treatment first. First, you should start with mydriatic cycloplegics. These are given immediately to tighten the lens zonules and pull the displaced lens posteriorly, and should be continued indefinitely to maintain posterior displacement of the lens iris diaphragm and prevent recurrence. Then, aqueous suppressants and hyperosmotics should be given to shrink the vitreous volume. Steroids should be given to decrease ocular congestion and inflammation. Then, if this medical treatment fails, you can go on to laser hyalodectomy. In this NDAG laser, disruption of the anterior vitreous face is done, which allows direct passage of the misdirected aqueous into anterior chamber. In pseudophakic and aphakic eyes, it is performed through the pupil after posterior capsulotomy. However, in phakic eyes, it is done through a peripheral iridectomy between the ciliary body and lens spaces. If successful, there will be immediate deepening of the anterior chamber and a reduction of IOP. Then laser cyclophotocoagulation is done. It is usually done after failure of NDAG laser anterior hyalodotomy. Single session of treatment less than a quadrant is sufficient. Coagulative necrosis and shrinkage of the ciliary body causes posterior rotation of the ciliary process. Surgical treatment is anterior vitrectomy combined with excision of part of the lens or zonules to establish communication between vitreous cavity and anterior chamber. In phakic eyes, lens removal and intraocular lens implantation may be necessary in addition to vitrectomy. Management of the fellow eye is also important because it is at the risk of developing this condition after any incisional surgery. So, prophylactic measures can be avoidance of miotics, prolonged use of postoperative cycloplegics, and prevention of postoperative shallow anterior chamber. So, this is a patient who came to me with ACIOL without PI and an IOP of 80 millimeters of mercury. Both peripheral and central anterior chamber were shallow. So, patient was diagnosed with malignant glaucoma. We did a peripheral YAC PI and an anterior hyalodotomy. Immediate deepening of the AC and the reduction of IOP was noted. And after 5 days, the AC was well formed with IOP of 10 millimeters of mercury. Now, coming to angle closure due to ciliary body rotation. Medical treatment with cycloplegic steroids and aquasuppressants can be given. Miotics are contraindicated. Prostaglandins can be used with caution since they can exacerbate UVL effusion. And if unresponsive, laser iridotomy, iridoplasty or drainage of the suprachoroidal fluid and reformation of AC is done. To conclude, different mechanisms of secondary angle closure presents with specific clinical signs, the identification of which allows for directed treatment of the underlying pathophysiology. Success of medical treatment and surgical intervention is a direct reflection of the underlying etiology. Thank you.
Thank you. Thank you, Dr. Priyanka, for the excellent comprehensive coverage of the topic. Any questions from the audience? Or sometimes it is difficult to distinguish between this pupillary block mechanism and push mechanism because both will have shallow chamber. So in push mechanism, you will have a shallow peripheral as well as central chamber, whereas when you have a pupillary block mechanism, you will have a peripheral shallowing and the central chamber is formed. So that is one way of distinguishing. But sometimes it becomes quite confusing, and sometimes we may choose to do a PA even in a push mechanism glaucoma. Something like a sulfur drug reaction is actually not required to do a PA, but I've seen surgeons who are advising for a PA because there may be a mixed mechanism component they're suspecting. Any additional comments, sir?
Yeah, in lens-induced glaucomas, especially phacomorphic and all, it is very likely that there is some amount of pupillary block mechanism also. So we anyway go ahead and do a PI, and many a time we say that the IOP comes down following PI, and it also helps because it increases the anterior chamber depth. So when you're doing surgery, it becomes that much easier, because otherwise you may be having a patient on table without an anterior chamber. It will be like kind of totally, the lens will come and touch the cornea, so you may find it very difficult to form the AC even with viscoelastics. So do a PI in case of phacomorphic and lens subluxations. Some amount of anterior chamber will form. It might help you in doing surgery. Yeah.
Any comments? Anything to add? Nothing? Okay. I'll go next.
Yeah, so I'd like to